The Recovery Kernel. Substance-Specific Navigation Series. How to recover from kratom. Using the Recovery Kernel Framework. Kratom, Mitragyna speciosa, Biak, Ketam, Kakwam, Tom, Herbal Height, Green Mangda, Red Bali, White Borneo. Warning: harm reduction resource, not medical advice. Crisis, call 911 or text 988. Kratom withdrawal is opioid type. Buprenorphine can manage it. Ask for it. CYP3A4 interactions can dramatically increase kratom's effective dose. Check your medications. A note before you begin. The Recovery Kernel Compendium places kratom in the opioid withdrawal protocol without qualification: opioid withdrawal, heroin, fentanyl, oxycodone, kratom. The opioid type withdrawal profile is acknowledged directly in the custody medical section. Kratom/high mitragynine products, moderate, opioid type withdrawal profile, opioid receptor dependent, symptoms begin 12 to 24 hours, similar curve to opioids. This guide exists because the clinical system has not kept pace with kratom's rapid proliferation. An estimated 1.7 million Americans use kratom regularly, making it one of the fastest-growing substances in the U.S. market. Yet many physicians have never heard of it. The FDA has attempted scheduling and failed, the DEA has not classified it federally, and the person experiencing kratom withdrawal in an emergency department or custody setting is frequently met with a physician who either does not recognize the clinical picture or does not know what to do about it. Kratom is unique in this guide series for a specific reason. Many people using it began by trying to solve a legitimate opioid problem. The person who switched from oxycodone to kratom to manage chronic pain without a prescription was making a pragmatic harm reduction decision. The person who used kratom to self-manage heroin withdrawal was being resourceful. Both may now have a kratom use disorder that requires the same framework as opioid use disorder, because kratom's primary active compound, 7-hydroxymitragynine, is a partial mu-opioid receptor agonist. The solution became the new problem. The guide holds both. Kratom also has a pharmacological identity that no other opioid in this series has. At lower doses, it is stimulant-like, not opioid-like. The dose-dependent polarity of kratom, stimulant at 2-5G, opioid at 5-15G+, means the person using kratom for energy and focus is using a different pharmacological entity than the person using it for pain management or euphoria. Understanding which profile applies determines the recovery architecture. Section 0, Immediate Safety. Warning: kratom withdrawal is real and opioid type. Severe cases include intense muscle aches, vomiting, diarrhea, insomnia, and anxiety that require medical management. Buprenorphine has been used successfully. Ask for it by name. 0.1 High-dose kratom overdose. At very high doses, particularly with concentrated kratom extracts or 7-hydroxymitragynine isolates, kratom produces opioid-type respiratory depression and sedation that can be life-threatening. Standard overdose signs apply. Severe sedation, difficulty waking, slowed breathing. Call 911. Naloxone may partially reverse high-dose kratom toxicity through its opioid receptor antagonism, but naloxone's coverage of kratom's full pharmacological profile is incomplete. Administer if available and call 911. Mitragynine and 7-OH-mitragynine are not reliably detected on standard opioid urine screens. Tell emergency personnel the specific substance. 0.2 QTC prolongation, the cardiac risk. Warning: mitragynine has documented QTC prolongation potential. Combined with other QTC prolonging medications, certain antidepressants, antipsychotics, antibiotics, antifungals, cardiac arrhythmia risk is elevated. Chest palpitations, racing heart, fainting, or dizziness during kratom use, cardiac evaluation, ECG, is indicated. Disclose kratom use specifically to the treating physician. 0.3 Liver injury warning. Warning: kratom has been documented to cause drug-induced liver injury, DILI. Jaundice, yellow skin or eyes, dark urine, severe abdominal pain, or extreme fatigue are warning signs. Stop kratom and seek emergency evaluation immediately. Kratom-induced hepatotoxicity typically presents 1 to 8 weeks after initiating use or after dose escalation. The pattern is often cholestatic or mixed. Some cases resolve with cessation, severe cases require specialist hepatology management. 0.4. Contamination, what may be in the product. Salmonella. Kratom powder has been implicated in multiple salmonella outbreaks in the U.S., 2018 FDA advisory. Fever, diarrhea, and vomiting after kratom use may be infection rather than withdrawal or overdose. Heavy metals, lead, nickel, and other heavy metals have been found in kratom products above acceptable limits in testing. Chronic heavy metal exposure compounds the neurotoxic burden of kratom use. Alkaloid content variability. Kratom powder alkaloid content varies dramatically by batch, vendor, and storage. A dose that was effective and manageable from one batch may be much higher or lower from another. Dose finding cannot be reliably transferred between products. Fentanyl adulteration, rare but documented. If overdose signs are more severe than expected from kratom alone, assume possible fentanyl contamination. Naloxone indicated. Section 1. What kratom did to your brain. Classical building the centurion, the dose-dependent polarity, stimulant at low doses, opioid at high doses. Kratom, Mitragyna speciosa, contains over 40 alkaloids, but two dominate its pharmacology: mitragynine, the most abundant, 60–66% of total alkaloids, and 7-hydroxymitragynine, 7-OH-MG, present in small amounts but highly potent. Understanding these two compounds and their dose-dependent relationship explains why kratom acts as two entirely different substances depending on the dose. 1.1. The two pharmacological identities. 1.2. The CYP3A4 conversion, Y7-OH-MG is the clinical target. 7-hydroxymitragynine is metabolically produced from mitragynine primarily by CYP3A4 in the liver. This metabolic conversion is why CYP3A4 inhibitors dramatically affect kratom's clinical effects. They cause mitragynine to accumulate while also increasing 7-OH-MG production relative to clearance. The result, at the same kratom dose, a CYP3A4 inhibitor, grapefruit, fluconazole, many HIV ARTs, some antibiotics, certain antidepressants, can produce dramatically more opioid-like effects and dramatically higher dependence risk. 1.3. What kratom was providing, 3 distinct user profiles. 1.4. The escalation pattern. Kratom tolerance develops through the same mu-opioid receptor downregulation mechanism as prescription opioids. The person who started at 3–5 G for energy and clarity finds that the energy effect requires 6–8 G, then the opioid effects emerge at that dose, and the dose that previously produced mild stimulation now produces significant opioid-like dependence. This escalation is pharmacologically identical to the shift from therapeutic to problematic opioid use, because the mechanism is the same. The compendium's opioid escalation framework describes this exactly. The dose that landed in the therapeutic window initially moves toward the euphoric window as tolerance develops. In kratom, this translates to the low-dose stimulant profile gradually shifting into the high-dose opioid profile as tolerance requires higher doses to achieve any effect. Section 2. Your genomic blueprint. Kratom's pharmacogenomics closely mirror opioid pharmacogenomics for the high-dose profile and stimulant pharmacogenomics for the low-dose profile. The defining genes are the same as for opioids, with the specific addition of CYP3A4 as the primary metabolic gene. Phenotyping without testing. Did kratom produce much stronger opioid-like effects than you expected at doses others tolerated without significant effect? Possible CYP3A4 inhibiting medication creating 7-OH-MG accumulation. Did kratom suddenly feel much stronger or weaker after starting a new medication? CYP3A4 interaction. Check your medications against a drug interaction database. Did low-dose kratom specifically feel stimulating and clarifying before higher-dose opioid effects developed? Warrior COMT plus adrenergic low-dose kratom profile. Did you use kratom specifically to manage opioid withdrawal or chronic pain? The original pain or opioid problem is a concurrent recovery target. Section 3, Medication-Assisted Treatment for Kratom. Classical building the centurion, the opioid receptor is the target. The opioid MAT framework applies. Because kratom's high-dose dependence is mediated by mu-opioid receptor activation, through 7-hydroxymitragynine, the same MAT framework as for opioid use disorder applies. Buprenorphine has been used successfully for kratom withdrawal management in multiple case reports and series. 3.1 Buprenorphine for kratom withdrawal. Evidence: multiple case reports and clinical series describe successful buprenorphine induction for kratom withdrawal, with good symptom management and patient retention. The same partial mu-opioid agonism that makes buprenorphine effective for heroin and prescription opioid withdrawal applies to kratom. Precipitated withdrawal caution: the same concern as with fentanyl applies here. 7-hydroxymitragynine has high mu-opioid receptor binding affinity. Buprenorphine given before adequate kratom clearance may precipitate withdrawal. The Bernese microdosing induction protocol, low-dose buprenorphine started while some kratom is still in the system, escalated gradually, has been used to avoid this. Discuss with your prescriber. Practical access: any DEA-registered provider can prescribe buprenorphine, since the X-waiver removal in 2023. Tell the physician specifically, I am dependent on kratom, which acts as a partial mu-opioid receptor agonist. Buprenorphine has been successfully used for kratom withdrawal. I am requesting evaluation for buprenorphine-assisted management. Duration: as with opioid use disorder, extended duration of buprenorphine treatment, months to years, is associated with better outcomes than time-limited courses. The underlying opioid receptor dependence that developed through kratom may warrant sustained MAT. 3.2 Extended-release naltrexone. After complete kratom cessation, typically 7 to 10 days of abstinence, extended-release naltrexone, Vivitrol, blocks mu-opioid receptor activation and removes the reinforcing properties of any kratom use. OPRM1G allele carriers show the strongest response. Requires complete clearance of kratom before initiation. 3.3 Clonidine for withdrawal symptom management. As with standard opioid withdrawal, clonidine, alpha-2 agonist, addresses the autonomic symptoms of kratom withdrawal, anxiety, sweating, restlessness, elevated heart rate and blood pressure, through the same HPA axis mechanism as in fentanyl and heroin withdrawal management. Available by prescription. Does not address the opioid-specific withdrawal symptoms as completely as buprenorphine but is often available through more settings. 3.4 The kratom taper. Classical building the centurion, the self-managed approach, and its limitations. Kratom's opioid-type dependence is theoretically amenable to tapering, and many people attempt self-managed kratom tapers before seeking clinical support. The principle is sound. Gradual dose reduction allows receptor adaptation, but the execution faces specific challenges. Alkaloid variability between products: a taper based on grams of powder cannot be precisely executed because alkaloid content varies dramatically between batches and vendors. Switching vendors mid-taper introduces uncontrolled variables. Dose measurement precision: kratom is typically measured by gram weight, not by alkaloid content. True precision tapering requires consistent product from a consistent source. The extract trap: high extract products are far more difficult to taper than powder because the alkaloid concentration variability is even higher. A general taper framework, not medical advice. Discuss with a physician. Reduce total daily dose by 10% every 1 to 2 weeks. Do not jump more than 10% per reduction. Hold at each step until stable before reducing further. At low daily doses, 1-2 g total, cessation may be more manageable than further tapering. Section 4, Biological Reconstruction. Kratom biological reconstruction combines the opioid recovery framework, endorphin system rebuilding, or receptor recovery, with elements of the stimulant recovery framework, dopamine reconstruction for the adrenergic low-dose component, plus kratom-specific hepatic support. 4.1 the methylation foundation. 4.2, endorphin system reconstruction. DLPA, D-L-phenylalanine, 750 to 1,500 mg morning enkephalinase inhibitor, extends the life of endogenous opioids. Primary opioid recovery supplement applied directly to kratom recovery. Supports the endogenous opioid system that kratom was activating pharmacologically. NAC, 600 to 1,800 mg daily, divided glutamate homeostasis, craving reduction. Multiple trials supporting NAC for opioid spectrum craving reduction. Omega-3 DHA plus EPA, 2, for G daily-amor receptor membrane environment, anti-neuroinflammatory. Same rationale as fentanyl and opioid recovery. Vitamin D3, 3000 to 5000 IU with K2, morning with fat endorphin synthesis support, documented deficiency in opioid use disorder populations. 4.3, dopamine reconstruction, for stimulant profile users. L-tyrosine, 500 to 1000 mg, morning, away from protein dopamine precursor for the adrenergic component of kratom's low-dose effects. Rhodiola rosea, 300 mg, morning dopamine and serotonin modulation, adaptogenic anti-fatigue. The energy deficit of kratom cessation in low-dose users is partly dopaminergic. Brain stack, uridine plus DHA plus CDP choline, D1/D2 receptor density restoration for users whose primary kratom use was at the dopaminergic/adrenergic low-dose range. 4.4, liver support, kratom-specific priority. Warning liver function testing, AST, ALT, GGT, bilirubin, is recommended for all significant kratom use histories. Kratom-induced hepatotoxicity is documented and may require hepatology management. NAC, serving double duty here, liver support plus craving reduction glutathione precursor directly relevant for hepatic recovery from kratom-induced liver injury. Milk thistle, silymarin, 150 to 300 mg standardized extract, daily hepatoprotective, antioxidant, specifically relevant for kratom liver injury recovery. Alpha-lipoic acid, 300 mg, morning, away from meals mitochondrial antioxidant, hepatoprotective, blood-brain barrier crossing. Avoid alcohol during recovery. Kratom-induced hepatotoxicity combined with alcohol creates compound hepatic stress. Complete alcohol cessation while liver enzymes are elevated. 4.5, the withdrawal timeline. 4.6, sleep protocol. Kratom withdrawal produces severe insomnia. The opioid system's role in sleep architecture means its sudden absence disrupts all sleep stages. The compendium's opioid withdrawal sonic protocol applies directly, 60 to 75 BPM, warm frequencies, bass, mid-range, 528 Hz, ambient, new age, classical strings, nature sounds, legato, no silence gaps. Magnesium glycinate, 400 mg elemental evening, GABA support and anxiety reduction. Melatonin, 0.5 to 1 mg sublingual, consistent bedtime, circadian signal. Glycin, 3,5G, 30 minutes before bed, temperature reduction and NMDA coagonism. L-theanine, 200 mg evening, alpha wave promotion without sedation. Hydroxyzine, prescription non-addictive antihistamine anxiolytic, useful during acute withdrawal insomnia. 4.7, peptide support. BPC 157, daily, oral mu-opioid receptor pathway modulation, gut-brain axis repair from kratom's GI effects, dopamine and serotonin normalization. C-Lank, weeks 1 to 8 as needed GABA and serotonin modulation, non-addictive anxiolytic, addresses the anxiety of opioid system withdrawal without addiction risk. CMAX, week 2 onwards BDNF upregulation, cognitive repair, prefrontal cortex support for the impulse control and decision-making impaired by chronic mu-opioid receptor activation. Section 5, the kratom craving, understanding and interrupting. Classical building the centurion, the dual craving, opioid-type relief-seeking and stimulant-type energy-seeking. Kratom cravings have two faces depending on which profile was primary. For the high-dose opioid profile user, the craving is for pain relief, emotional warmth, and the absence of withdrawal. For the low-dose stimulant profile user, the craving is for energy, focus, and productivity. Both are real. Both have specific triggers. Both require specific interrupts. The Kratom Craving Interrupt, 5-minute protocol. Identify the craving type. Is this opioid profile, pain, withdrawal, warmth-seeking, or stimulant profile, energy, focus, productivity-seeking? The specific underlying state determines the specific additional response. Take DLPA and NAC. The endogenous opioid and glutamate substrate of the craving. These are pharmacological interventions for a pharmacological state. Execute 4-7-8 breathing, 6 cycles. Parasympathetic activation for the HPA axis overdrive of opioid withdrawal craving. For pain-driven craving, execute the pain management plan. Contact your prescriber if pain is above threshold. The craving is accurate, the pain is real. The solution must be real too. For energy/focus craving, vigorous movement for 10+ minutes immediately. The adrenergic activation of exercise provides a genuine, albeit brief, alternative to kratom's adrenergic effects at low doses. Contact your support structure. Name the trigger. Name the type. The isolation that kratom use often involves is itself a craving driver, connection is the countersubstance. Document. Trigger, type, intensity, action, outcome. 3 weeks of documentation reveals the specific pause pattern and the triggers most associated with relapse risk for this specific person. Section 6, Building the Natural Architecture for what Kratom provided. Classical Building the Centurion, C28 applied to Kratom, 2 natural architectures for 2 pharmacological profiles. Because Kratom has 2 distinct functional profiles depending on dose, the natural porting architecture must address both. For the opioid profile user, the endorphin architecture. From the Fentanyl Guide's natural porting framework, applied identically here because the receptor target is the same. Vigorous sustained exercise, 45+ min daily the primary endorphin activator. Direct MOR activation through endogenous opioid release. Non-optional. Genuine human connection and physical safe touch, oxytocin and endorphin co-release through the social bonding pathway. Cold exposure, endorphin surge and norepinephrine activation simultaneously. Service to others with chronic pain or opioid history, the specific meaning and MOR activation of genuine contribution. Low-dose naltrexone, LDN, 1.5 to 4.5 mg nightly by prescription paradoxically upregulates endorphin production through brief receptor blockade. Particularly relevant if chronic pain drove kratom use, LDN has evidence for fibromyalgia and chronic pain conditions. For the stimulant profile user, the dopamine adrenergic architecture. From the Stimulant Recovery Guides, applied to the adrenergic/dopaminergic low-dose kratom profile. High-intensity exercise with competitive element, the natural dopamine norepinephrine activation that matches the stimulant profile's low-dose kratom effect at the biological level. Mastery at the skill frontier, flow-state dopamine through the challenge skill edge. ADHD treatment if indicated, the Warrior Comp ADHD profile that drove low-dose stimulant-seeking kratom use. Treatment removes the primary driver. Caffeine strategically, if managed not a substitute for kratom but a genuine adrenergic tool for the energy profile. The Energy Drink Intelligence Guide strategic caffeine architecture applies. Pain management, the third natural architecture. For users whose kratom use was primarily pain management, the natural porting must include a genuine pain management plan. This is not optional. Physical therapy, the most evidence-based non-pharmacological pain intervention for most musculoskeletal pain. Exercise-induced endorphin analgesia, directly reduces pain perception through the same MOR pathway kratom was activating, at lower intensity but sustainably. Buprenorphine for pain plus OUD, addresses both pain and opioid receptor dependency simultaneously. Non-pharmacological pain interventions, mindfulness-based pain reduction, MBSR, acupuncture, TENS, heat/cold therapy, sleep optimization for pain management. Section 7, Navigating the Recovery Kernel, Your Protocol Map. Section 8, The Medical Context, The Regulatory Limbo. Kratom's legal and regulatory status creates specific challenges that no other substance in this guide series faces. Federally legal in the U.S., as of 2026, the DEA backed off scheduling after massive public opposition in 2016. Kratom is not a controlled substance federally, but is banned in Alabama, Arkansas, Indiana, Rhode Island, Vermont, and Wisconsin, and several municipalities. No FDA-approved use. Kratom is not FDA-approved for any medical purpose. The FDA has issued multiple warnings about Kratom products and has attempted to remove them from the market through import alerts and enforcement actions. The Kratom Consumer Protection Act, KCPA model legislation developed by the American Kratom Association that would regulate Kratom for quality, labeling, and age restrictions without banning it, has been passed in several states. Provides a regulatory framework for harm reduction within legal use. Clinical documentation challenge. Because Kratom is not in standard drug panels and is not a controlled substance, the medical record may not accurately reflect Kratom use history. Specifically disclosed to all treating physicians. Having the physician conversation. I have a Kratom use disorder characterized by dependence on mitragynine and 7-hydroxymitragynine, partial mu-opioid receptor agonists. I am experiencing opioid-type withdrawal. I have been researching buprenorphine-assisted management for Kratom withdrawal and I am requesting evaluation for this approach. This framing requires the physician to engage with the clinical picture, not dismiss it. A final word. Classical building the centurion, the plant that was supposed to be the solution, and then became the problem. Many people reading this guide came to Kratom with the best possible reasons. They were getting off opioids without a prescriber. They were managing pain that the medical system had either undertreated or overtreated. They were finding energy for a demanding life without the criminal implications of stimulants. They were doing harm reduction, imperfectly, with what was available. The Compendium C37 principle, every substance preference is a signal, applies here with specific compassion. The Kratom preference was a signal, a pain system that needed management, an energy system that needed support, an opioid receptor-mediated relief from something that genuinely hurt. The signal was accurate. The solution was temporary and developed its own problem. Recovery from Kratom is not a moral correction. It is finding what the plant was providing, pain relief, energy, endorphin-mediated warmth, through means that do not themselves require management. The endorphin system the body was given can be rebuilt to provide the pain buffer that Kratom was pharmacologically supplying. The dopamine architecture can provide the energy and focus that low-dose Kratom was adrenergically delivering. The opioid MAT framework that the clinical system largely reserved for heroin and fentanyl users applies to you. Buprenorphine works for Kratom withdrawal. Ask for it by name. The physician who does not know about Kratom's mu-opioid mechanism needs to be informed, and this guide provides the language to do that. You were solving a real problem. Recovery is solving it better. American Kratom Association, americankratom.org Treatment Locator, findtreatment.gov Crisis, 988. Refer to the Recovery Kernel Complete Centurion Compendium for all referenced protocols. Crisis. Call or text 988 Emergency, 911 SAMHSA, 1-800-662-4357. How to recover from Kratom using the Recovery Kernel Substance-Specific Navigation Series.